My next presentation, we're going to cover a bunch of different territories. We're going to talk about Doppler evaluation of the abdominal aorta and the branch vessels, meaning the renal and mesenteric arteries. So in this presentation, we're going to go over normal flow patterns. I believe that this is really the most important aspect of the talk. When you know what normal is, then it's much easier to pick up abnormalities. We talked about abnormal flow patterns in the carotid system and lower extremity veins. It's very similar when we talk about the branch vessels of the abdominal aorta. Picking up the abnormalities is where you're really going to pick up significant disease. We'll go over the protocols related to abdominal studies, and we'll review the diagnostic criteria for aortic aneurysm and renal and mesenteric artery stenosis. So I'm going to start out by talking about the preparation of the patient and the protocols. When we plan to do our abdominal studies, the aorta, renals, and mesenterics, we like to have the patient fasting from the night before. Try to schedule as many as we can in the morning, although we do perform these studies throughout the day. By having the patient fast, then we can reduce the amount of noise that we get from the patient, which causes scatter and attenuation. We don't give any other medication or other preparation other than have the patient fast. But I think it's really important for those who perform these studies to recognize that there are certain views that really facilitate the examination and help your team be very efficient. We do these studies in 10 to 20 minutes. So these are thought to be very long, tedious examinations. But when you know the shortcuts, these examinations do not have to be that time consuming. For example, looking at the renal arteries, we turn the patient so that we're scanning through the liver to see the right renal artery. And here's a beautiful view of the right renal artery in its entirety from the aorta all the way to the renal hilum. And when you have this view and you have a normal flow pattern and you don't see aliasing, you can presume it's going to be a normal vessel. All you have to do is get your velocity measurements because there's no evidence of a flow disturbance there. So again, that window here makes the job so much easier. Here we are again, scanning through the liver. For the left renal artery, we turn the patient left side up, we scan through the kidney. It really facilitates the examination. For the abdominal aorta, again, turning the patient side to side, moving away from the bowel gas, shifting the bowel gas to the side, allows you to see the aorta very well. Another thing to consider is optimizing the color Doppler image. I think the key as well is not just identifying blood flow, but looking for flow disturbance. In the example on the top, we're looking at a normal right renal artery. And you see here we have a normal flow pattern. We don't see any flow disturbance. We don't see any aliasing, any brewy artifacts that would tell us there's an underlying abnormality. So here we are. We can lay the vessel out. We see it. We can get our samples. We even see this early branching of the right renal artery here, and we can sample those branches. So we contrast that with what we see below, and here we see the findings associated with a significant left renal artery stenosis. We see aliasing right at the origin. You can see the color change. We see the flashing that occurs in systole in the surrounding tissues, the brewy artifact that is associated with a high-grade stenosis. So by adjusting the gain, the PRF, the wall filter to laminar flow, these flow disturbances really stand out, tell you where the abnormality is, allow you to place the sample volume in the area of interest so you can get the highest peak systolic velocities to grade the lesion. So adjusting the color gain and the PRF allows you to really screen the vessel very quickly. And then, of course, we're going to get our samples from the distinct locations in these arteries. And again, angle correction is key. So we're going to use a small sample volume, usually 2 to 3 millimeters, maximum size, angle correcting to 60 degrees or less along the direction of blood flow, and making sure we adjust the pulse repetition frequency and the scale so that we can visualize the waveforms so that we have a normal rapid systolic upstroke and we can characterize the diastolic flow. So again, we're going to talk about normal flow patterns first, remembering that the proximal aorta and those branch vessels, namely the celiac and the renal artery, are supplying low resistance beds of the liver and the spleen and the kidneys. So these organs demand continuous forward flow throughout the cardiac cycle, very much like the brain. So the waveforms that we're going to get from the renal arteries, the hepatic artery, the celiac artery, are going to have a similar waveform shape as the internal carotid artery. Rapid systolic upstroke, continuous forward diastolic flow, because they're feeding those low resistance organs. When we talk about the distal aorta below the level of the renal arteries, then we're talking about the high resistance beds of the lower extremities. So signals from the distal aorta typically are higher resistance. Similarly, with the mesenteric arteries in the fasting state, those vessel beds are contracted. You get high resistance waveforms, as you'll see. So I try to take a very practical approach to these studies, regardless of whether we're looking at mesenteric branches or renal arteries. You know, we train our sonographers to start out with a grayscale image, look for the presence of plaque. As I mentioned before, if there's no plaque, if it's a normal looking vessel, there should be no underlying stenosis. So we look for the presence of plaque with grayscale, we turn the color on and look for either laminar flow or flow disturbance. Again, by adjusting and optimizing the color display, you can easily see when there's evidence of a flow disturbance. And very obviously here, you see this alias signal throughout the superior mesenteric artery in a patient with a severe SMA stenosis. And so we're going to sample in that area. We get those abnormally high velocities. And as we move through, as you see here, in the post-stenotic segment, we get post-stenotic turbulence, that bidirectional shaggy waveform. Again, that confirms you have a high-grade lesion. And of course, the measurements will go along with that. Grayscale, again, just an example here showing plaque at the origin of the left renal artery. When we see that, then we would expect that we may see some abnormal flow. We know where to sample. If the vessel is dilated and it's aneurysmal, then again, it's very helpful to start out with grayscale. We also will see evidence of dissection, as I'll show you in a couple of minutes. You may not see a dissection when the color is on. The color can override the flap. So you want to turn the color off, especially if you think there could be an underlying dissection. Here's another example with the color on showing the narrowing at the origin of the celiac artery. We see the jet. We see the aliasing, so it's very straightforward. We know where to sample, and many times in real time, we'll see the color bruit, the flash that occurs in systole at the site of the stenosis. In terms of diagnostic criteria, again, I try to keep it very simple. Primary parameters are going to be the peak systolic velocities, and we know what the cutoffs are. The secondary criteria are going to be ratios, and ratios work. Ratios have proven to be very valuable in a number of arterial applications. So we'll look at velocity ratios, and again, look at the secondary signs. I think they're very helpful. Post-stenotic turbulence, TARDIS waveforms. I like to see at least 2 abnormal criteria to be definitive that we have a significant lesion. You usually do. If you have a high-grade stenosis, you'll have high velocities, but in addition, you'll have a higher ratio, and you'll see post-stenotic changes. We know there's a pitfall for just looking for velocities. We see this all the time. Young patients coming in for renal artery studies typically have high velocities. That doesn't mean that they necessarily have a stenosis. So again, you want to see at least 2 of these criteria to be definitive about the diagnosis. In terms of absolute velocities, usually over 200 is considered abnormal. But again, not in every case. But that's the cutoff we think about. The exception to that is for the superior mesenteric artery, we use a cutoff of 275. So the renals, the celiac, the IMA, 200 is the number we think about. But again, not reliable in all patients, because you'll have some patients that have relatively low velocities, even with stenosis, because of poor cardiac output, underlying cardiac disease, and as I mentioned, high velocities in your younger patients. So that's where the velocity ratios can come in. If you have really high velocities or very low velocities, you do the ratio. For example, in the renal arteries, we know we have a renal aortic ratio. We compare the velocity in the renal artery to the abdominal aorta at that level. Right? If it's 3.5 to 1, we know that that is a significant stenosis because the velocities are so elevated. In general, anywhere between 3 to 1 to 4 to 1 is considered a significant ratio that would be consistent with stenosis. And again, these have been validated for numerous applications, for the carotids, for the renals, and for the lower extremities. And we've already talked about poststenotic signals. I emphasized those when we talked about the carotid arteries. And also, we will see that with these branch vessels as well. When you move the sample volume through the stenosis, you get the really high velocity flow, move it into the poststenotic area. You see the waveform break down. It changes, and you start to see the shaggy waveform shape and bidirectional flow because the red blood cells are spinning in the poststenotic area. So we have these cute names that we use, shaggy waveforms, picket fence, Bart Simpson hair, all describing the abnormality that we see on our display. And because there's a pressure drop, the velocities drop precipitously in that poststenotic area. So let's move on. We'll talk about the abdominal aorta. We all know the normal diameters are going to be less than 3 centimeters. It can be up to 2.7, but it depends on the patient. Normally, we think about the normal diameter about 2 centimeters. And again, as I mentioned, it supplies both low and high resistance arterial beds, that cutoff being the renal arteries. So now looking at the abdominal aorta on a grayscale image, we know the aorta, it normally tapers as we get below the level of the renal arteries. Again, normal diameters up to 2.3 in men, up to 2 in women. We say it's an ectatic aorta when it's somewhere between 2 to 3 centimeters. Obviously, over 3 centimeters, we do consider it aneurysmal in most patients. The normal velocity range for the abdominal aorta is 60 to 100. Again, very easy to remember. We said for the carotid arteries, it was 60 to 100. For the aorta, it's 60 to 100. For the renal arteries, it's 60 to 100 and on. Common femoral artery, as I will tell you again, is 60 to 100. Very easy to remember. When we're talking about the large abdominal aorta, it should give us sort of laminar plug flow. In other words, all the red blood cells are moving at about the same velocity at any given point in time. And reiterating again, proximal aorta, low resistance waveforms, looking at the sample on top, continuous diastolic flow because it's feeding the celiac and the renal arteries. Once we get below the renals, then it's feeding the lower extremities, high resistance, and we'll have diastolic reversal. The protocol, again, and I'm sure most of you are familiar with the examination of the abdominal aorta. We want to sample proximal, mid, distal, and the common iliac arteries. The one thing to remember and to reinforce with your sonographers, it needs to be outer wall to outer wall. That is how we measure the abdominal aorta. I like to do it perpendicular to the long axis, meaning on a sagittal view. I don't like the measurements as much in a transverse view because of the fact that you can overestimate if you're not perpendicular to that axis. So I like to use, as you see here, a longitudinal view, get the long axis of the vessel, outer wall to outer wall measurement. And as you can see here from the chart, the rupture rate increases with increasing size. We say after 5 centimeters, the patient is a candidate for surgery. Once the aneurysm is greater than 6 centimeters, 50% 1-year survival rate, 43% risk of rupture. And of course, these aneurysms are typically infrarenal. Now, I mentioned the fact that you can pick up dissection, and notice here on these images, I turn the color off. You're going to see the dissection best on the grayscale image. Now, we all know that the dissection usually starts from the thoracic aorta and can extend inferiorly. Could be due to atherosclerosis, most commonly also seen after trauma, Marfan's disease, as an intimal tear or flap that we can visualize. One of the things that can make it tricky is that the false lumen can thrombose, so you don't see full flow, and it may look like it's just plaque or thrombus. But again, easier to see it when you turn off the color. Here's an example here, grayscale and color. Grayscale on top, the flap is there, you can see it, just sort of moving with arterial pulsation, and then below with the color on, we see the true lumen feeding the celiac and the SMA, and slower reversal of flow in the posterior false lumen. Treatment of AAA, as was already discussed, can be surgical repair or endovascular stent placement. Here's just some examples. We do use both CT angiography and ultrasound to look for evidence of endoleak, which is the most common complication status post-stent repair. CT is considered the primary imaging modality. It is certainly better than color Doppler alone. In my experience, because I do a lot of contrast-enhanced ultrasound, that really has become the standard for my patients because of the fact that it's very, very sensitive. Here's an example here of a type 2 endoleak with the arrow pointing to blood flow coming into the sac retrograde from the inferior mesenteric artery. So the objectives of studying patients after stent repair, you want to obviously measure the maximal aneurysm size. That is really the key to studying patients after they've been treated with EVAR. If there's no change in the sac size, regardless of even if you find an endo leak, they're probably not going to do anything. It's the increase in the size of the sac, which means that the leak is causing increased pressure within the aneurysm, causing it to enlarge. That has to be treated. So many of the patients that we find with type 2 endoleaks are followed until there's a change in aneurysm size. So that is really the key. Obviously, what we also want to do is assess for flow in the stent graft. As you see here on the color Doppler image, the graft is patent, but there should be no flow in the excluded aneurysm sac. And here are the different types, which I know you're familiar with. The type 1 is when there's a leak from either end of the graft, either the proximal anastomosis or distally. Type 2 is when the branches bring retrograde blood flow back into the sac, typically either from lumbar arteries or the inferior mesenteric artery. Type 3 is when there's a defect or a hole in the graft and blood comes out of the graft and fills the aneurysm sac. Those are the types that we look for. Here are some examples. This is a type 1. The leak is at the proximal anastomosis of the stent graft. We could see it coming across the top and filling the aneurysm sac. That obviously has to be treated. Here's a type 2 endoleak. We see here blood flow is coming into the sac from a lumbar artery coming in posteriorly. We can follow that in. That is one of the advantages of ultrasound. You really can see the leaks very well. CT will identify a leak, but it won't tell you the origin of the leak in most cases. So that's one of the advantages of doing this. So here, a type 2A is a simple one branch leak. Type 2B is when you have multiple sources of the leak. We usually find one, but on occasion you will find two. Type 2 endoleaks, as I mentioned, are the most common, and they tend to be lower pressure. So you can follow those after they've been identified. Here's a type 3 endoleak, and this is coming from a hole or a defect in the graft. And here on the color Doppler image, we see that blood flow is escaping from the graft and starting to fill in the sac. Same thing that we see here on the CT angiogram. As I mentioned, we do mostly contrast-enhanced ultrasound. Many advantages. There's no radiation to the patient. There's no need to give iodinated contrast, which is a benefit to the patient. We can do as many studies as we want, and again, with little risk to the patient whatsoever. We can detect low-flow endoleaks that CT angiography does not find. And I know this is a fact because many of the low-flow endoleaks that we find that are not seen on CT go on to angiography and they are confirmed. Again, another advantage here is that we can classify the type of endoleak. We can say whether it's a type 1, type 2, type 3, and it allows the interventionalist or the cardiologist or vascular surgeon to know how to treat that patient. When you see an endoleak on CT, you typically don't know where it's coming from. So we can visualize the hemodynamics and again, avoiding contrast and radiation. A meta-analysis of contrast-enhanced ultrasound compared to CT angiography was done. 26 studies were reviewed. Again, contrast-enhanced ultrasound showed very high sensitivity and specificity, particularly for types 1 and 3. And again, I think some of the decreased sensitivity is due to the fact and specificity is that not all of the endoleaks are picked up on CT, but they are real. They're very low flow endoleaks, and contrast-enhanced ultrasound is very sensitive. Let's move on and we'll talk about the renal arteries. Again, these are patients that come to us looking for atherosclerotic renal artery stenosis. They may have fibromuscular dysplasia. I can tell you many patients come to our practice because they have ischemic nephropathy. They have abnormal renal function, may or may not have high blood pressure, and they're looking to see if renal artery stenosis or occlusion is the cause of the abnormal renal function. Our protocol for doing these studies, we start out with the kidneys. We look at the kidneys for hydronephrosis, stones, masses. Then we do a direct examination of both renal arteries from their origin to the hilum of both kidneys. And then we finish up doing the indirect exam, looking at the waveforms from the segmental arteries at the renal hilum. And we'll go through that. So here's, looking at our renal survey. And this is a case that we had not that long ago. You can see there's this large echogenic mass projecting from the upper pole of this right kidney. This was a renal cell carcinoma, and again, incidentally picked up looking at the renal arteries. So we look at the size of the kidneys. Obviously, if they're small and atrophic, greater concern that there is underlying renal artery stenosis, but we also look for hydronephrosis and stones. In this particular case, I turn the color on. We see the increased vascularity, the neovascularity associated with renal cell carcinoma. Here is part of the direct examination. Again, we're going to scan the renal artery. We're going to take samples from the origin, proximal, mid, and distal segments of the renal artery. And then, of course, we're going to also take samples at the hilum of the segmental branches. Again, the velocities somewhere should be normally between 60 and 100. Low resistance, and we want to make sure our angle corrected to the direction of blood flow. When we do the indirect exam, we're placing the sample volume in the hilum at the segmental branches, looking at the waveform shape. Remember the normal renal artery waveform, rapid systolic upstroke, continuous forward diastolic flow. These are abnormal. There's a slow rise to peak, and we call this a tardus parvis waveform. It indicates there's an inflow abnormality. Here's some more examples of normal renal arteries. Again, just to show patient position, really helpful. Again, scanning the right renal artery through the liver, the left renal artery through the kidney. We can see it in its entirety. Very simple for the sonographer then just to grab those samples. That's why we can do these so quickly. In terms of the criteria for the renal artery study, again, we said 200 centimeters per second is what we consider to be the cutoff, but I also will always do the renal aortic ratio. If someone has a velocity of 250 but a low ratio, I'm not likely to call that renal artery stenosis unless I have other signs, such as tardus parvis waveforms and post-stenotic turbulence. So we look at all of the different features and try to get as many signs as possible. Another example of a tardus waveform, these are abnormal waveforms that we obtain from the segmental branches at the hilum of the kidney. Again, and we're just looking for that delayed systolic upstroke, and it should be distal to the stenosis. So, TP, tardus parvis, it looks like a TP, right? And, some folks will do, the acceleration time from the waveform. Some will look at the acceleration index. I've trained my folks so that they look at the waveform. If you have a waveform that look like that, you don't really need to do these indices. The machine will do these calculations for you, but I think sometimes just looking at them and comparing them side to side really is helpful, as I'll show you. You'll notice here from this paper that, the normal waveform is on the left, rapid upstroke, continuous diastolic flow. With increasing severity of stenosis, you'll have increasing degrees of tardus parvis till it basically just looks like a rolling hill with severe disease. Here's some examples. Here's a patient that presented with right renal artery stenosis. You can see the aliasing where the arrow is there, disturbed color flow. The velocity there is almost 400 centimeters per second. If I move the sample volume into the hilum, I see a tardus parvis waveform. But remember, you're not always going to see tardus parvis waveforms, as I'll talk to you. It is very specific. It's not that sensitive. Many patients, including older patients and patients with severe atherosclerotic disease, will not give you tardus parvis waveforms. Here's a patient that has a left renal artery stenosis. Again, here we have a velocity over 700 centimeters per second at the site of the stenosis. Compared to the aorta, it's less than 150. Obviously, a very high ratio. And we have tardus waveforms in the left hilum. Compare it to the contralateral side. I know some people sometimes struggle. Is that a tardus parvis waveform? Look at the other side. On the other side, we have a nice normal-looking waveform with an early systolic compliance peak. You see that there? That's the normal waveform. And if you compare it to the other side, they're very different. So it's very helpful to compare the waveforms. Here's a patient that had fibromuscular dysplasia, long segmental stenosis of the right renal artery. The velocity in the mid-segment where this stenotic is over 300. Compare it to the renal artery at the origin was only 84. So again, marked increase in velocity in the stenosis. Again, for me, the definition of a stenosis is a focal elevation of velocity. And that's very important when you do your renals. If you have high velocities throughout the whole renal artery, that's not a stenosis. It has to be a focal elevation of velocity to be stenotic. And if you look at the MRA in this case here, the arrow is pointing to the segment of fibromuscular dysplasia that is seen in the right renal artery, but you'll also notice here there's FMD involving both iliacs. I'm going to share some data with you that we did this study years ago. We looked at over 3,000 patients that came to us for renal artery studies. We looked at these different parameters: elevated velocities, ratios, TARDIS waveforms, and resistive indices. And what we found is the most sensitive criterion is the peak systolic velocity. It's sensitive, not necessarily so specific. What adds specificity is the renal aortic ratio and the presence of TARDIS waveforms. TARDIS waveforms are not that sensitive, but they're very specific. So if you think about this, it's very much like the carotid exam. When you think about carotid arteries, the most sensitive criteria is the velocity. Specificity is added by looking at the ratio. Similar here. Oh, and by the way, resistive indices, of very little value. It's like flipping a coin. So I never look at resistive indices in terms of determining whether there is renal artery stenosis. Abnormal resistive indices are helpful in patients that have abnormal renal function. They're helpful specifically when we're evaluating renal transplants. Here's an example of a patient pre and post-stent. You could see a TARDIS parvus waveforms in a stenosis pre-stent. After the stent, the waveform normalizes. So it's helpful to look at waveforms after stents are placed. Renal artery occlusion, you see a small kidney and absence of flow in the renal artery. Renal artery aneurysms, you can pick those up. Here's a nice example of an aneurysm extending from the renal artery, confirmed on arteriography. Typically see it in middle-aged patients. 90% of them are extrarenal, and it can be associated with FMD and Ehlers-Danlos. And typically will go on to repair when they're at least 3 centimeters. We can also look for evidence of renal infarcts. Here's a paradoppler examination. You can see there's no flow in the upper pole, confirmed on the CT. Where you can see that wedge-shaped defect. We use contrast-enhanced ultrasound now routinely for looking for infarcts because it's so easy. But this is a nice example using power Doppler. And finally, in the last few minutes, I'm going to talk about mesenteric stenosis. Patients who present with severe acute abdominal pain, we're concerned about acute occlusion, they go on to CT angiography. The patients that we scan in the lab with Doppler are those that have chronic abdominal pain. They may give you a history of fear of food because every time they eat, they get postprandial pain. And they may also complain of weight loss and only eating small meals because of the pain they get after a meal. Now, infarction and ischemia can be related to arterial obstruction, may also be related to venous thrombosis, or it can be due to non-occlusive disease, very slow flow, as in patients who are hypotensive or in shock. So again, chronic mesenteric ischemia is a syndrome of postprandial pain and weight loss, usually associated with atherosclerotic syndromes. And we can evaluate that in a number of different ways. Grayscale imaging, as Dr. Fishman was talking about yesterday, you may see some nonspecific findings, bowel wall thickening, ascites, some distension, and we're going to look at the vessels to see if they're patent. In order to call the syndrome of chronic mesenteric ischemia on a Doppler study, we want to see at least involvement of 2 of the 3 mesenteric vessels. In other words, we want to see stenosis or occlusion of the celiac, SMA, or IMA. At least 2 of those should be involved. Again, normal waveforms are really important to understanding what stenosis looks like. Again, here, celiac artery. Again, we mentioned this already, because it provides blood flow to the liver and the spleen, should have lots of diastolic flow. The mesenteric arteries, on the other hand, are going to have high resistance, little diastolic flow in the fasting state. That changes after a meal. There's increased blood flow with digestion as there's vasodilatation of the mesenteric vessels to improve digestion by increasing blood flow. But in the fasting state, when we typically do these studies, you see very little diastolic flow. And the aorta at this level should also have continuous flow. Here are some normal fasting duplex measurements. You can see here somewhere between 100 and 140 centimeters per second. The criteria that we use, as I mentioned before, 200 centimeters per second is the criteria we use for the celiac and the IMA. For the SMA, it's 275 centimeters per second. That's the exception. We've done studies where we would be able to identify the cutoff for the IMA, did these years ago. And, in our experience, we see the IMA in about 90% of cases because we do it all the time. And you can identify the IMA by going on a transverse orientation from the abdominal aorta right below the renal arteries. You'll see the IMA coming off anteriorly going to the left, as you see in this case. We also did a review of the diagnostic criteria for mesenteric stenosis, looking at peak systolic velocity, ratios, and end diastolic velocity. Again, as you would expect, the velocity is the most sensitive. It's also fairly specific in the mesenteric circulation. The ratio also adds specificity. So these are the recommended criteria that we use for the mesenteric studies: 200 for the celiac and the IMA, 275 for the SMA, a ratio of greater than 3:1. And again, we also look for those secondary signs, meaning we look for poststenotic turbulence. Here's a couple of examples. Here's a 68-year-old presenting with abdominal pain. The celiac was patent. The velocity was not that elevated, 130, but you can see disturbed flow and a Bruy artifact at the origin of the superior mesenteric artery, where the velocity is 400 centimeters per second. We also looked at the IMA. You can see disturbed flow up here on top. We can see aliasing at the origin of the IMA, where the velocity is over 360 centimeters per second. The aorta was only 72, so we have high velocities and high ratios in this patient with chronic mesenteric ischemia. We can also identify patients that have mesenteric ischemia and abdominal pain from mesenteric vein thrombosis. This is seen about 10% of the time, but very relatively high mortality. These tend to occur in younger patients and have a variable presentation. In this example here, we can see this thrombosis of part of the splenic vein. Here's an example of a patient presenting with abdominal pain and elevated liver function tests, and we can see thrombus in the portal vein, the splenic vein, and when we change the orientation from a transverse view to a longitudinal view, we can track the thrombus down the superior mesenteric vein. And this was all confirmed on CT. Finally, the last thing to mention is the median arcuate ligament syndrome. I'm sure many of you have heard about this before. This is fairly common, especially in young women. You can see that there's compression of the median arcuate ligament by a leaflet of the diaphragm. And what happens is, at rest or with expiration, that diaphragm will compress the anterior aspect of that celiac artery, causing a functional stenosis, which is very nicely seen here on the MRA. And you can see here where the median arcuate ligament will press down and cause a stenosis of that celiac artery. And it's best seen at expiration or in resting. With inspiration, the leaflet comes up, it takes off the compression, so you'll have relatively normal velocity flow in the celiac artery. But if you have the patient taking a deep breath and look again, you will see this sort of fish hook appearance where the celiac artery is tugged down, and you will get relatively high velocities with expiration. So you can see here, inspiration is only 170, expiration is over 400. Again, very common finding, particularly in thin young women. Doesn't mean that there's necessarily disease, but it is thought to be a cause of pain because not necessarily from arterial compression, but it is thought to be related to compression of the nerve. Some patients respond to surgical treatments, some do not. So I'm going to finish here as my time is up. Successful abdominal Doppler studies, they really depend on recognizing normal waveforms, looking at the changes that occur with significant stenosis. Of course, optimizing the image facilitates the examination, as we discussed, and integration of the diagnostic criteria with the physiologic changes that we see on our spectral analysis is very helpful. Thanks for your attention.